This week on the Core Ultrasound podcast, I'm going to show you an interview that I had with Dr. Gabe Rose, who's a physician at the Kaiser Hospital here in San Diego. He's also the co-fellowship director for their POCUS fellowship there. I'm going to show you an interview I had with him about something that we don't usually look into, which is doing injections for pain for carpal tunnel syndrome in the emergency department. Now, this is not something that we do a lot of, or even honestly, full disclosure, I don't even really think about it all that much as a possibility, but why? We give pain medicine, we do injections, we alleviate suffering for so many other things that are at least as bad and as painful and as debilitating as carpal tunnel syndrome. Why not do this thing that is really pretty similar to things that we already might be pretty comfortable with, like a median nerve block at the midform? We just got to do it a little more proximally, right? There's a couple other structures we have to be careful with, but once we kind of know the technique and we have a sort of baseline of how to perform good needle guidance under ultrasound, it's definitely something that we can do in the emergency department and even in our clinics. Check it out. Hello, and welcome to the Ultrasound podcast. My name is Jalen Avila, and we have a very special guest, Dr. Gabe Rose, who you might know from TikTok. Has a lot of good educational content on there, is a regular ER doctor, well, not regular, I'll say a phenomenal ER doctor, as well as the co-director of the Ultrasound Emergency Fellowship and Division at Kaiser San Diego, right here in my hometown as well, a great surfer and, wonderful human being in general. We both nerd out on nerve blocks, and we're going to talk about a couple of, we'll say like nerve block adjacent blocks, right? Because for some of them, they're not what we think about for nerve blocks. We think about them a lot for like fractures and traumatic injuries, but there's a lot of other applications in pain relief. We're going to talk about two things. Gabe, I repeat like a lot and quickly when I get excited. I'm so excited about these two case series that you published that we're going to talk about.
Thank you so much for the introduction. Yeah, I'm super excited to talk about this. This is really near and dear to my heart. This is sort of my niche and favorite part of what we do with point-of-care ultrasound. So I'm happy to get into it.
Yay. Now, there's two of them. One of them is for carpal tunnel syndrome, and then we're going to do another one for shoulder pain. I think we should probably talk about the carpal tunnel first. Mm-hmm. Initially, when I think about this, I think that I want to consider it a little less important than like an interscalene block or the intrafascial block, which we'll talk about later. But when you look at the numbers, carpal tunnel syndrome affects a way higher number of people than we have with, I would argue, with chronic shoulder pain where they can't lift their arms. Has that been kind of like your experience and the push behind looking into this in the emergency department?
Yeah, absolutely. So I think some literature will quote up to about 5% of the population prevalence for carpal tunnel syndrome with a predominance in females. So we certainly see them, although it's not the most common thing you'll get on your day-to-day shift in the emergency department. I think that there are a good number, at least enough to warrant discussion and investigation and looking for alternatives of treatment. Because not only do we get a good number of people with carpal tunnel syndrome, but I think that it goes to say that there might also be patients that come in with hand and wrist pain that are undiagnosed with carpal tunnel syndrome as well. So this is kind of an important solution that we can look into.
Absolutely. And, we're both emergency medicine docs. And I also think about, like, my brother, for instance, is a family medicine doc. And so he actually sees that more than we do. And then I think about how much they probably see it, and then how much sports medicine, maybe even orthopedic surgery, because they're the ones that do the operations. This is like a cross specialty problem that I'm not sure that we all uniformly treat in the same way.
Yeah, I agree with you. And I think that that's kind of the main drive for this. And it's a point of frustration that I've had with it, let alone a lot of other MSK pathologies. And, that was kind of the main motivation that got me looking into this in the first place. because I wanted to kind of break away from the status quo, right? We'd see a patient, we take an x-ray, we rule out any emergent pathology like a fracture dislocation. We start them on an NSAID or something similar, send them out to either follow up with their family practitioner or orthopedic surgery, and never really hear from them again. Now, the problem is when this starts to affect people who are closer to you in life, so friends and family, and you think to yourself, oh, x-ray, NSAIDs, follow-up, but that may not always be feasible. And more importantly, we get a lot of patients who have already done that for months or years and have failed the conservative treatments. And all those factors combined really got me to thinking about how can I push the envelope and break the barriers a little bit.
So what kind of made you even consider this as a treatment? Is it just because of your scope? I guess we'll say the glasses that you look at everything with, because you're there's not one thing that defines you. You're a multifaceted person. But we often, when we're lecturing together, when we're talking, we're discussing nerve blocks, right? I mean, is that the kind of how you kind of came up with doing this in the emergency department?
So I've tried nerve blocks for carpal tunnel before. And interestingly enough, I've had times where it helped temporarily. I've had times where it wasn't very successful. And I've had times where, the patient's pain went away, but then they were complaining that, well, now their hand is completely numb and asleep and they can't really use it. And we all know that nerve blocks have a lifespan of a few hours to begin with. Even the longest ones may be maximum for about a day. So when patients ask, how long is this going to last? You tell them, anywhere from, 6 to maybe 12, 16 hours, depending on your agent. I actually fell on the idea of hydrodissection by accident. I was listening to a podcast similar to this, and there was a physician who specializes in regenerative medicine who was discussing carpal tunnel treatments using perineural hydrodissection, which was totally new to me. I didn't know what that was. I got excited about it. I looked it up, and immediately a spark went off, and I realized that this has broad potential, not only in outpatient, but especially in the emergency department, because it can give you great short and long-term effects. And it also differs from blocks in general because it's not a block per se. What we're doing is we're actually working to reverse the underlying pathophysiology of many of these nerve entrapment conditions, predominantly carpal tunnel syndrome. And I think that's the power of this procedure, is it offers immediate relief because you're decompressing the nerve, but it also works to start restoring that nerve dysfunction back to normal.
Well, that is a phenomenal explanation. Now, I'll be honest, I'm not super familiar with the concept of just doing hydrodissection. I mean, as an ER doctor, it's mostly blocks. I want to anesthetize an area. How is hydrodissection different? And what are you even using to hydrodissect? Is it just saline?
So this is a great question. Well, historically, hydrodissection really is not something we see or are accustomed to in the emergency department. And when you look up literature, there really isn't much out there, especially for the use in the ED. More so, it's in the outpatient settings, such as orthopedists, physiatrists, people who practice regenerative medicine. Mm-hmm. And that's what it's a branch of. And so, as the name implies, you're using an injectate to hydrodissect, or to bluntly open with the fluid itself and separate a compressed nerve from its surrounding compressing tissue, which is usually fascia or perimysium. So different agents have been used historically for hydrodissection, and the most commonly used one, because it's one of the most well-studied and has been shown to have the most positive effect, is D5W, which is basically sugar water. And that's how I explain to the patients, I'm just injecting sugar water. The beautiful thing about D5W is that it's pretty inert, so it doesn't cause any inflammation in the tissues. It has little downsides. You're not going to increase the patient's glucose. You're not going to cause irritation of the tissue, inflammation, anything like that. And the dextrose in the solution itself actually has a property where it acts on what's called the TRPV1 receptors, which quiets the overall firing of these capsaicin-like receptors on these large nerves to decrease some of the pain response that the patients are having from chronic compression. So that's actually sort of the what I'd call pharmacological, quote-unquote, approach to D5W. But the main point is that what you're doing, unlike a nerve block where you're just injecting anesthetic around or one side of a nerve, you're actually decoupling the tissue from the nerve itself. So you're releasing the nerve from its compression. And that's kind of how hydrodissection differs from a traditional nerve block, is not only you're not really using local anesthetic, but now you're aiming to get fluid above and below the nerve to completely separate it out from its surrounding tissue.
Do you see pain because of that inhibiting of the capsaicin receptor that you mentioned? Do you see relief in the emergency department when you do this, even if you don't use, lidocaine or any kind of local anesthetic?
I think this is why I hold on to this procedure so dearly, because the first couple times I experimented with it, and I've done it for different indications at this point, what I noticed is that I inject and I clean up my sharps and all the wrappers and the syringes. And as I start to prepare the patient for understanding a little bit more about the expected outcomes, they're already feeling better. So you're seeing differences in these patients within a matter of anywhere from 5 to 10 minutes. And I think that's what is so incredible about it, is that there's almost an immediate effect. There have been times where I've injected patients with hydrodissection using T5W, whether for carpal tunnel or other indications. And literally, as I can see in real time under ultrasound guidance, that nerve separate from the fascia. They say, whoa, something just happened. I felt the pain stop. And I just can't, I can't attest to that.
Powerful.
Yeah. I can't
Just with
attest
sugar
to that.
water.
Just with sugar water. I can't attest to that with other agents like local anesthetics. We all know when you do a nerve block, you have to allow some time for it to work. And, some people find it very uncomfortable to have their entire limb or part of their limb asleep. This is just a discontinuation of that radicular pain. And I think that it's incredible because you preserve that motor and sensory function.
Wow, that is intense. Now, could this work for other kind of chronic issues? If someone's complaining of like chronic elbow pain, chronic shoulder pain, which we'll talk about that also in the next section, but could you just do D5W for any chronic pain, nerve/muscle chronic pain issue? This video is sponsored by Cloud Lifewear. Check it out, cloudlifewear.com. Thank you so much for sending me some much needed new scrubs. Now we have an amazing color, coral. We have this top, which has a flutter sleeve, and the neckline, which I just adore. We have some joggers, really nice quality, super comfortable, and pockets, which we need those. And if you happen to get cold, you can wear the vest, which it is actually like really soft, comfortable material. And I see myself using it for all sorts of non-ER stuff. And we also have some base layers, which this is super soft and I bet really like warm as well. And then there's this one, which is a very stretchy, comfy, soft tee that I'm very excited to try out. This top is actually super soft. I actually see myself wearing this like outside of the ER easily. And it's also really soft and stretchy. Thank you to Cloud Lifewear for sending these. And now back to your video. Wow, that is intense. Now, could this work for other kind of chronic issues? If someone's complaining of like chronic elbow pain, chronic shoulder pain, which we'll talk about that also in the next section, but could you just do D5W for any chronic pain, nerve/muscle chronic pain issue?
Also a great question. I think it depends on the etiology of that chronic pain. If it's in fact a pain that's caused by compressive neuropathy, so another highlight that we have performed it for is sciatica or deep gluteal syndrome, where we decompress or hydrodissect out the sciatic nerve in the transgluteal region. I've done this for occipital neuralgia or cervicogenic headaches. There are patients who have thoracic outlet syndrome or compression of their distal brachial plexus, and you can hydrodissect that out. Another extremely common example is ulnar tunnel syndrome, where it's sort of like the carpal tunnel, but in the ulnar tunnel. And it's a very common indication in the outpatient setting for using this, as well as radial compression, radial nerve compression. So if there is a compressive neuropathy and you can image it and access it, you can do it.
Are there any, out of all of those, the one that I think in my practice would probably have the biggest impact would be sciatic nerve pain. And I know that we have in emergency medicine literature, we've definitely have well described doing a transgluteal nerve block for pain, but using local anesthetic. My issue with that is that the sciatic nerve is a very important motor nerve as well. And so I struggle with the idea of discharging somebody with, maybe like 40% utilization of one of their legs, right? Because you still have the femoral nerve and that does the anterior muscles, but all those the buttocks, the hamstrings, everything in the posterior part is affected from a motor perspective. And I have heard anecdotally other of our ultrasound colleagues describe situations where patients actually unfortunately had a traumatic knee injury because their leg wasn't stable. And then they just tweak their ACL as they walk out. Is there any evidence, any studies in the ER that do hydrodissection using D5 for sciatic blocks or for sciatic pain?
So I'm glad you asked that. As it happens, we published a case series about 2 years ago of using a transgluteal hydrodissection of the sciatic nerve to treat acute sciatica in the emergency department. We had, I think in the series, we had maybe 4 or 5 cases highlighted. But at this point, we've done many, many more. And the beauty of it is, as you describe it, unlike the traditional sciatic nerve block, which is also very powerful and effective for fast-term relief, you don't get that foot drop. You don't get that nerve component, that motor nerve component that you would with a block. But most importantly, even if you do offer them good pain relief, and they somehow can ambulate well despite the block, you have to prepare them that the pain may return in a period of anywhere from 8 to 12 hours after that anesthetic wears off. However, if you're doing the hydrodissection, which thankfully, if you're comfortable with the transgluteal nerve block, the procedure is not all that different. You just have to fully mechanically separate the fascia on both sides of the nerve. Mm-hmm. Those patients we've seen have pain relief at least for a week. And this is based on a current prospective trial that we're doing in the emergency department now for this procedure. And we've been following up with our patients at 72 and up to a week, 72 hours and a week after. And for a good number of the patients so far, many have had pain relief beyond the 3 days, extending up to a week, which is kind of amazing.
That is amazing. That's amazing. If you are interested in a multi-center, let me know. Because we do, at my hospital, we've published a case series on doing an out-of-plane. Well, we use what we call the way out-of-plane technique for lumbar back pain. And it's basically an ESP block where we go, have the transducer where we're supposed to for an ESP block. And instead of coming in plane, we go essentially center the transverse. What am I thinking? What's that transverse part of the vertebral body?
On the transverse process?
Thank you. Process. That's what I forgot. So you basically aim for the transverse process, put in the middle, and then just go straight down with the needle until you hit the bone, and then watch the hydrodissection happen. And it's worked well for us as well. And so we're a chronic back pain center of excellence, I feel like. So all that to say, I am very interested in this because that's, I know we're talking about carpal tunnel, but these are kind of pain nerve entrapment syndromes that dramatically affect patients' lives. So I think, especially with the sciatic, puts them at risk for opiate dependence and just chronic pain in general, which is a horrible thing to deal with.
Absolutely. And here's the thing, I find that for patients, whether it's carpal tunnel or sciatica, in the traditional approach that we often employ, at least that I used to employ, was a toradol injection if they're candidates for that, a lidoderm patch, and probably some kind of systemic opioids. They might feel partial, minimal relief. Some of them may not have any relief and be admitted for continued opioids. And then there's always the risk that is involved with, systemic NSAIDs and opioids, and you're worried about dependence, addiction, side effects. I've even had patients tell me, I feel high, but I'm in pain. So,
right.
This is the key difference is let's nip it at the bud.
I love that. Now, going back to carpal tunnel, what are some, I guess, risks, right? Because we're talking about how amazing it is, but are there any risks involved with doing this? Anything we should be careful with when we're consenting patients? Is there things we should tell them as potential complications?
Absolutely. I think anytime you're doing any procedure that involves inserting a needle into skin, you have to take your standard precautions and provide informed consent. There's the typical risk of pain, bleeding, or infection involved with introducing a needle underneath the skin. Additionally, I think that, as powerful and as simple as this technique can be, it still requires a degree of comfort with your in-plane ultrasound-guided needle technique. So if a physician is interested in starting this but hasn't done many nerve blocks or, IV catheter insertions under ultrasound guidance, it's a good idea to get some phantoms in practice, whether they're homemade or like DIY or from, some of the commercial phantoms, just so you're really comfortable guiding your needle under an ultrasound to a specific target. Because you don't want to inject intraneurally as it would be for any block or needle procedure. You don't want to get the needle to skewer that median nerve or tendon and inject right into that structure. So having comfort is important. And then, of course, the typical pain, bleeding, or infection is always important to discuss. And I would never really do this if the patient had an ongoing cellulitic infection overlying that region.
Brilliant. All right. So what we're going to do now is we're going to show how to perform the technique. If you want to figure out what the diagnosis of carpal tunnel is, there's a lot of physical exam and historical findings that you can look for to increase or decrease your suspicion, but you can easily use ultrasound to diagnose it as well. And if you want to know that, I'm going to put the links in the show notes, but you can also go to YouTube or to the website and type in carpal tunnel in the search function.
We are going to be looking for the median nerve. This is going to be just deep to the flexor retinaculum. We are going to use anisotropy to localize the nerve. We're going to fan the probe, and we see that the nerve there in the center of the screen is not changing its color relative to the tendons. We can also follow it more proximally, and we see that it is not dissolving into muscles like the tendons do. All right, so we're going to be doing this from the ulnar aspect. This is going to be an in-plane approach right at the end of the wrist. This is right at the carpal tunnel inlet. So we're going to go in with our needle, and then we're going to go just above our nerve, and we're going to inject about 5 cc's of normal saline solution. We're going to inject just above it. All right, now we're going to instill another 5 cc's just deep to the nerve.
So that was the technique. And Gabe, once we do this, right, this procedure, is it just they're cured forever? And we just discharge them? What are next steps, I guess?
Wouldn't that be nice?
Yeah.
No, I think this is a great adjunct. Hydrodissection is amazing, but it's never a panacea. And I think it's used as an adjunct to other modalities of treatment. So I still, recommend physical therapy. I still put them in a splint, especially at nighttime. Many patients have this issue of sleeping with their wrists hyperflexed, which compresses the nerve. So that still helps, ice packing for any swelling or discomfort or soreness. And then, of course, pass the baton, have the patients follow up with their family practitioner or orthopedist or hand surgeon is always key as well to make sure that they're doing better. In some cases, when patients have this performed as an outpatient, it may take more than one injection to have that long-term benefit that we see with it. So outpatient follow-up is still crucial.
Brilliant. That makes sense. Now, I was going to put the, is it infra or intrafascial block?
Interfascial plane block.
Interfascial block for shoulder pain. But I think let's do that on a part 2. We'll do that next week. I'm very excited about focusing on carpal tunnel. We also did a bit on doing this for the sciatic block, which I would love to actually get you on in the future to talk specifically about that one, because that one's fascinating to me. Do you have any other kind of points, any ending things, any shouts out that you'd like?
So thank you so much. I think I just want to say thanks and shout out to Joshua Fuchs, who is on the carpal tunnel paper with me, and for all his efforts, as well as my current fellows, Billy and TJ, and all my previous fellows who always indulge me and allow me to get them involved in these fun projects and pushing the envelope. Shout out to the ultrasound division and Deja at KP San Diego. And please check us out if you haven't already. We have social media content for KP Sono, and that's at KP Sono, both on Instagram and X. We also have a TikTok page as well, where we post some fun short video blurbs about using ultrasound to treat our patients.
I love that. Well, thanks so much for stopping by, and hopefully we'll run into each other soon.
Thanks so much for having me.
I hope that was helpful for you all, and I know that I will be significantly more heavily considering doing this hydrodissection, this carpal tunnel release procedure under ultrasound guidance, thanks to the stuff that I learned from Dr. Gabriel Rose. Special thanks to Dr. Tyler Yates and Dr. Billy Shank, who are Deja Essner and Gabe Rose's fellows there at Kaiser San Diego. You guys are amazing and great educators. I hope to hear from you soon, and happy scanning.